All right, good evening. We are here in Success. This is your Zoom lesson for the week. And I wanted to review the plan. So this is the 1 hour Zoom. I'm going to review, do exam review and go over some of the pharm key points. I still have to put up that lesson. And then we'll continue with skills testing on Thursday. If there's any specific questions you want to review, add them here. Catlin has one that we'll go over in a little bit. And then I'm going to post the questions that you turned in, the week 4 questions. Most of them were really good. So I think it's a good idea to review those. So we will do that on Thursday as well. So if we're looking into week 5, the concept for the week is pain. And we want to do prep for next week because Monday in class is the exam. So I wanted to review any stress busters or anything that you find stressful when taking an exam. So, earplugs, headsets are good, deep breathing, aromatherapy, getting a good night's sleep, those types of things, deep breathing, just kind of take your time with the exam. And we're going to review that here in a few minutes. We will review the quizzes for theory and pharm. I will do that in Success, but I will also do that on Thursday. I think at 10. I'll let you know, but we will go over that. And I do want to do that for the whole class. Ms. Clark does not have time. She has a lot to cover for Thursday, so she's not going to take time on Thursday to review, but we will do that to help for the exam. Put that down here. Okay, so the exam question distribution with objectives was posted on announcements. I don't know what happened. The announcements all disappeared, but I got them back. So I have this posted right now also in the NRN 56 announcements, but I copied and pasted it here for you. So you would have it here as well. It's the exam 1 is worth 100 points. There's a few, maybe 2 or 3 select all that apply. Can be multiple choice, matching, fill in the blank, drop down, short answer. There's at least 3 short answers. And those are moved to the end so that you have time to do that. You'll have approximately 90 minutes to complete the exam, and it will be in on campus. And we will start at 11. I'll be proctoring, so you know that. If you have accommodations through DSPS, make sure you notify them so that you can take the exam over in the B building. So that you have the distraction-free environment. So make sure you do that. All right, so going back to week number 1, healthcare law, ethics, communication. We kind of talked about a lot that week. And so the different objectives. So sometimes it'll be all of the objectives. Sometimes it will be just some of the objectives. So review the concept of ethics, like the type of ethics, principles, issues, dilemmas. So basically what you would need to know is examples of each type of the ethical principles. So fidelity, malfeasance, non-malfeasance, I can't even remember off the top of my head. I apologize for that, but you can find them listed in your book and also in the lecture. And then this was Catlin's question: discuss how ethics impacts nursing and healthcare for childbearing, child rearing families regarding patients' rights and informed consent. So basically, this focuses on ethics and would be kind of like if you had an ethical principle that you stood for, perhaps you were not in favor of abortion, but yet you had to make sure there was a consent on the chart for a client who was, for whatever reason, going to have an abortion. That might be an ethical dilemma. This question will center on informed consent. So who can give informed consent for procedures, et cetera. Applying communication skills, right, in the context of our nursing practice. We're getting really good at this. I'm really happy with the things that I'm seeing and hearing from you. This question, you need to know, we did a lot of examples of objective versus subjective. So you need to know examples of objective versus subjective data. And then modes of conflict resolution used by others and self. So what are, it's in the, they list some specific ones in the objectives for that week, but what we talked about was conflict management styles quiz. There was that quiz, and you were like an owl or a shark. It was kind of how you manage, you know, if you're a win-win or lose-lose, or you like to compromise, that kind of thing. So go back and review that conflict management style quiz and know what your style is and how you would respond, react in a conflict, in a situation in which there was conflict, and how you would resolve it. And then applying leadership management skills when delegating tasks to other healthcare personnel. That basically has to do with delegation. So review your 5 rights of delegation and know what the scope of practice is for different healthcare assistive personnel and VNs, RMs, that kind of thing. Okay, family dynamics, 5 questions. So be able to differentiate between healthy and dysfunctional families. So what are characteristics of a healthy family? What are some characteristics of dysfunctional families? And then we looked also at culture and spirituality in terms of the pregnancy, childbirth, child rearing, and we did that Padlet. So you have the link here that will take you to that Padlet, and you need to kind of understand why we did it. And I would take the time to go back and look and review things that other students posted, because there would be a question asking about that. All right, and then apply healthcare law to situations involving suspected child abuse or intimate partner abuse or intimate partner violence. So basically, healthcare law, and also being able to recognize, to assess for child abuse or intimate partner abuse. Now the objectives, the number of objectives may or may not match the number of questions, depending on whether there's a short answer question or there might be more than one question. So for example, in number 4 here, there might be a question on child abuse and also a question on intimate partner abuse. Okay, development. Whew, man. Okay, so common risk factors for developmental delay and primary, secondary prevention measures to mitigate delay. So to help that, to make it so that there's not as much delay. So what are some? Primary being education, primarily, and then secondary prevention being screenings to mitigate delay. Like what would be an example of that? Like the MCHAT or something like that would be a screening or some education. And then recognize the attainment of developmental milestones versus delay. We talked about autism and Down syndrome, use those as examples. So there will probably be questions about autism and Down syndrome and how to recognize that, or patient education, parent education. And then if you remember, in week 2, you were split into groups and you put together some sort of study sheets, worksheets based on the different developmental levels. And so from those lists, which are posted in the week 2 module, for each developmental stage, you need to know the certain characteristics underneath, only the ones that are listed. If it's not listed here, you don't need to know it. And so there can be any kind of combination of questions. This kind of information would lend itself well to a matching or a fill in the blank, or maybe a drop down where you click and it gives you several choices that match. And then nursing and collaborative interventions related to developmental delay, autism and Down syndrome. So that could be education, that could be interventions for feeding, for education, development, those kind of things. Okay, prenatal care. I will do my best, as these are Ms. Clark's points, but so antenatal diagnostic tests for fetal growth and well-being. So think about, what are those tests? What are antenatal tests that you've talked about, like non-stress tests, biophysical profile, any blood work tests that are done, what are particularly critical periods in embryonic or fetal development, what stage of gestation is a critical period in development, nursing and collaborative interventions to optimize reproduction, expected changes for second, third trimester. So what are some key points? There's probably, I'm sure there's a table or a summary someplace that talks about key physiological changes that happen in the first, second, and third trimesters in terms of, for the mom and the baby, the growth of the baby as well. Discomforts of pregnancy. So what, nausea, vomiting, aches and pains, and then teaching specific to clients' learning needs in each trimester. So you talked about expected physiological changes. So you kind of need to know what are things that are expected, what to expect when you're expecting for each trimester. And then any risks that are determined by prenatal diagnostic testing. So what kind of prenatal diagnostic testing will show you that there might be a risk for either the mother or the baby. Ultrasound, things like that, because an ultrasound can tell you where the placenta is. It can tell you if there are difficulties with the fetus, difficulties with the placenta. All right, week 3, fluid and electrolytes. So imbalances in fluid and electrolytes across the lifespan. So generally meaning in children and elderly. What are different risk factors? Oh, that's kind of the same thing there. So discuss risk factors, and then specifically hyperemesis gravidarum. We spent some time on that, and fluid loss through vomiting or diarrhea in the young child. What are lab values that you need to know, intake output from different sources to determine the type of fluid and electrolyte imbalance. So not so much to determine like if it's like hyperkalemia, hypokalemia, hyponatremia, but more in terms of lab values and or intake and output, or like a specific gravity or BUN creatinine, something like that, that would tell you, give you information for fluid and electrolyte status. Appropriate nursing and collaborative interventions to promote fluid and electrolyte balance. So we talked about oral rehydration therapy or solutions, IV fluid resuscitation, any electrolyte supplements, what kind of diets for various ages would you use? We talked about the brat, that we don't really use that anymore. So what types of food would be used for that? And then what kind of health teaching would you do in the home? So for somebody being discharged home, what might you tell them? Usually safety things or things to monitor. Moving on to hormonal regulation. Recognize when an individual has signs of impaired hormonal regulation, clinical manifestation. So what do they look like? What is it clinically that you can look at them and say, oh, they might be having an issue with this, and lab results that are indicative of, you talked about gestational diabetes mellitus, so different, the glucose tolerant tests, things like that. Know that thyroid disease, so what is indicative of hypothyroidism, hyperthyroidism, as well as parathyroid disease. Right, nursing and collaborative interventions, that's going to be on everything because that's what we do as nurses. And then specifically diabetic management during pregnancy. So diabetic management, including diet and exercise, self-monitoring of glucose, insulin administration, correcting for hyperglycemia, and fetal surveillance. So what are some things that we are looking for in the infant, or risk factors because the mom has gestational diabetes? What risk factors then might that present for the baby? All right, newborn adaptations. So the week 4 case study is a good resource. People did pretty well on that. I will go over that as well. But that's a good resource for you because it covers hypoglycemia, hyperbilirubinemia, normal care, car seats, all kinds of things. So that's a good resource. And I think those are all graded. If not, they will be tonight. So being able to recognize potential or actual like risk for potential or actual problems in the immediate neonatal period. So you're thinking of in terms of normal versus variations on the physical exam. So like caput encephalhematoma or hyperpigmentation, milia, things like that, things that we did during the newborn exam. And then specifically exam findings or behavior, things that we need to be able to assess for and interventions for the baby who's appropriate for gestational age, large for gestational age, small for gestational age, and then also to differentiate that from preterm and post-mature, post-term babies and what complications there potentially would be for babies in those categories. And then particularly looking at expected physiological changes versus complications. So respiratory distress, thermoregulation, sepsis. So we talked about, there's that one slide that we talked about in terms of sepsis, glucose regulation, hypoglycemia, and then physiological versus pathological jaundice. So knowing the different types of jaundice, the treatment for jaundice, knowing the treatment or things that you're going to monitor for hypoglycemia, signs and symptoms, interventions for neonatal sepsis, those types of things. And then also looking at appropriate nursing interventions for neonatal well-being, particularly prevention of infant abduction. So there are some slides in the Stable Newborn PowerPoint, I believe, that talk about things like, the name bands, mom and baby's name bands should match, and that the baby should have a transponder on, and it's on the umbilical cord clamp. I can't remember at SVMH if it's on the ankle or the umbilical cord clamp. But the transponder, you want to check at some hospitals, nurses in the mother infant unit have like a pink or a blue badge. It's something different that identifies them as nurses on that unit. You want parents to ask for identification, not let strangers in the room, which right now probably isn't going to happen. And then routine care of the newborn. So circumcision care, umbilical cord care, diaper changes, just regular newborn types of care. And then any signs and symptoms that should be reported to a healthcare provider. In terms of like circumcision, if there's bleeding or no urination, if the child has a fever, respiratory distress, things like that. All right, we are getting there. So problems during pregnancy. Describe the hemorrhagic conditions of early pregnancy. So including spontaneous abortion, ectopic pregnancy, and gestational trophoblastic disease. I believe you went over those in detail, so know the differences and know how they present and interventions that you would do. And then be able to explain disorders of the placenta. So placenta previa, which is a low-lying placenta that covers the cervix, and then an abruptio placentae, placental abruption, where the placenta is pulling away from the uterine wall. One of the students today described it kind of like a scab. You pull the scab away and then there's blood. It's kind of an odd one, but I thought it was a good picture in my mind. And so what are the, how do you know the difference? When the patient presents, what are the similarities or differences between placenta previa and abruption, and what interventions will you as the nurse have to do then? And then being able to compare RH and ABO incompatibility in terms of what causes it, and then fetal and neonatal complications. So we talked about hyperbilirubinemia, right? That can result from an ABO, which are blood types, incompatibility. And so the baby can have hyperbilirubinemia. And then what happens, for example, we talked about in the bubble in terms of RhoGAM. So when do you give RhoGAM? When When is it necessary? Is it the first pregnancy? Is it the second pregnancy? And why are you giving it? And what will it accomplish? Because if we don't give it, then the maternal cells start to kill off the fetal cells, and then that's not good. And then labor and delivery, 10 questions, because that's the topic that you will have this Thursday. Ms. Clark will be presenting that. And so looking in terms 1, 2, 3, 4, 5, 6, 7. So there's probably a couple questions on one of those. So physiological changes preceding labor. So basically, like, how do you know that perhaps the woman's going into labor? What are some things, signs and symptoms, things that you might educate the patient about? Are there contractions? Are there, is there the bloody show? Does the amniotic fluid, the sac break? And so there's amniotic fluid. Priority interventions for intrapartum emergencies. So when you're in the process of having the baby, what are some things that you need to be aware of in terms of perhaps bleeding, maybe a shoulder dystocia of the baby. So fetal monitoring, electronic fetal monitoring. So fetal well-being, I think, would be the category. And so in terms of looking at Category 1, Category 2, or Category 3, go back and look at the notes that, or look at the notes that Ms. Clark will give you, but it's also in the NRN 57 lecture. It shows you late decels and variables, etc. But there's also a section on Category 1, 2, and 3. So if you want to review that, you can as well. So basically, Category 1 is everything's good. There's good variability with the infant's heart rate. There's maybe some accelerations with the contractions. Baby recovers, and there's really no issues. Category 3 means prolonged decels, or maybe the heart rate is down below 100 for 5 minutes, 10 minutes, something like that. Category 3, you're generally on your way to the OR for a C-section. Everything in between is a Category 2. And so you basically watch that, and it can shift between the categories as well. And then also to know when you're looking at the fetal monitor, in terms of what is an acceleration, what is a deceleration, is there good variability of the fetal heart rate, what is the baseline of the fetal heart rate, that type of thing. What is the mechanism of labor in the vertex position? So vertex would be head down. And so what the stages and going through the, being high and then descending into the pelvis as when the cervix effaces and dilates. And then what are characteristics of false versus true labor? There's a table on that. And then nursing assessments during each stage of labor. So how many stages of labor are there? 1, 2, 3, 4 stages. And then what assessments are you doing in each of those? In terms of active labor, latent labor, the baby's actual birth, the delivery of the placenta, what are things that you are on the lookout for? And then procedures to assist with labor and delivery. So what, not so much medications, but sort of kind of that assist, like we know Pitocin to help with contractions, but perhaps a vacuum assisted delivery. Are there different positions that can be used? What are some things as a nurse that we can do? Different types of breathing, things like that, that are things that can assist with labor and delivery. And for example, if you're doing, this was in your case study, if there's a forceps or a vacuum assisted delivery, then what are you on the lookout for the infant, especially? Okay. So now that we've gone through that, if you have specific questions, and you can put them in the topic plan for week 5, I gave you those. We did that quiz review. All right, so let us look now. Right, we did that test. Okay, let's look at, I'll just go through 56 and make sure there's not anything that I missed, perhaps. Right, so week 1, remember, go through the lessons, that lesson. Right, you did the quizzes. Week 2, we talked about the development. So these are examples of each of those developmental stages. So whichever, you click on one and then go back and it says cognitive or fine motor, gross motor. So milestones to know, other need to know information, gross fine motor, that kind of thing. There will be questions like that on the NCLEX, also on the maternal newborn ATI practice quizzes that you're taking. And what else? Any of the case studies are going to be good practice. You guys did a great job with the baby Brianna case. Fluids and electrolytes. We had talked about different solutions, glucose regulation, thyroid problems, right? All those are there. And then last week we did newborn adaptations. So let me go ahead and then bleeding in pregnancy was what Ms. Clark covered. Let me look, I think it's this one in the lesson. Let me double check. Right, jaundice, infant abduction. So these are the PowerPoints to look at. We kind of did some things in the high-risk newborn and the neonatal hypoglycemia, hyperbilirubinemia, but there's also the stable nursing care and the newborn adaptation. So those are the PowerPoints to look at. You don't have to know fetal circulation right now. APGAR scoring, hyperbilirubinemia, those you do. Let's review the case study on baby James. I think I still have to, I have to grade a bunch of those. So I will keep working on that. Students are doing well for the most part with that. I just want to review so you kind of know what I was looking for and what things you need to know. So when we're looking at the birth and that transition from being inside mom to being out in the big wide world, what are some things that need to be done and assessed for during the first 2 hours after birth? So generally looking in terms of respiratory status, right? Oxygenation, breathing, their breathing, assessing their breathing pattern, perfusion, what is their heart rate, what is their cap refill, maybe in O2 sat, their pulse, their cap refill, thermoregulation, are they warm? What is their blood sugar? Are they jittery at all? Are they able to latch? We need to dry them to keep them warm. And then giving the medications within the first 2 hours. Some facilities, I know Trump does it within the first 4, but because there's really no evidence to show that 2 hours is better than 4 hours, but I believe SVMH and Tividat are still 2 hours in which to give the medications. So what are some measures you should use to facilitate respiratory effort and adequate oxygenation during the first 2 hours after birth? So once the baby's born, we want them to cry. We're going to stimulate them. If they're not crying, we're going to dry them off. And we're going to always assess. Remember to assess. So do a focused respiratory assessment. Assess the lung sounds. Assess the respiratory effort, O2 sats, things like that. What is the work of breathing? Is there grunting? If there's grunting, which I think happens later on here, then we're in trouble and we need to do some interventions. Skin to skin is also another good intervention that tends to stabilize all the vital signs. So what assessments would you complete on the newborn after a forceps? So forceps is actually where they take, it kind of looks like tongs kind of thing, and it would go, it goes inside mom around the head to help, kind of like a shoehorn. I don't know if y'all remember shoehorns, but kind of help ease the head out, or the vacuum delivery where there's like a suction cup that helps to pull the baby out. And so many people are correct, are going to check for bruising, and how's the scalp, is there caput, is there cephalohematoma, shoulder dystocia somebody thought of. What you need to know is that you need to monitor the baby for hyperbilirubinemia, because potentially with bruising, there could be some jaundice. And then caput versus cephalohematoma. Caput crosses sutures. Cephalohematoma could lead to some some different problems. And advantages of the mother-baby approach to healthcare. You guys had a wide range of answers and all of them were correct, right? Bonding and getting to know each other so the mom can see the signs and the cues that the baby's putting forth. It's kind of nice to have them together and do couplet care on our end to see them interact. And advantages for the baby and keeping the baby warm and used to mom as well. So security and safety measures. This varied. What I was actually looking for in this one was measures to prevent infant abduction, because that was one of the objectives. So the wristbands, the transponder, identifying the nurses working with the child. But many of you had like back to sleep and keeping the crib free of extra things and other safety measures that you mentioned for discharge home as well, which are all good. But I was thinking in terms of in the actual hospital, some other safety measures. And then the baby becomes jittery, hypoglycemia. Pretty much everybody got that. What interventions are you going to perform? So the first thing you're going to do is check a point of care blood glucose, right? And monitor, are there any other signs or symptoms of hypoglycemia? You're also going to assess when was the last feeding? Is there anything in the maternal history or in the birth record that could be a reason that the baby's jittery? So basically the results come back low, doesn't say what exactly. And so what is the normal range for a newborn? Some people had 30 to 60, some people had 40 to 60, some people went up as high as 150, all of which are correct, except I don't like the 30 being the low. I use like 40. I think that's what most standards, the book may have said 30, but once it's below 40, that's when we really start to worry. And then, 60, 70-ish for a high is good. If it's over that, that generally means the baby was stressed. So now what are you going to do? If they're hypoglycemic, what is your plan of care for the newborn? So the first thing is always feed the baby. So we have to feed the baby somehow, either get the baby to breast or supplement with formula or supplement with pumped milk. We're talking in terms of the newborn, but if it was, a day or two in, maybe the mom has some pumped milk, but we've got to feed the baby, and then we check the blood glucose according to facility policy, which is generally what I showed you in class. Like you're going to check about every 3 hours before the feeding. It's kind of like a peak and trough. It's kind of like a trough level, if you think of it that way. We're looking at the lowest level of the blood sugar right before the baby eats. And so that's what we want to know. And so your interventions helped, and it's now in an acceptable range. Yay. And we just said, according to protocol, probably every 3 hours before feeds or symptomatic. But now the baby started grunting and the temperature is 97.2 axillary. So that's kind of a low, on the low end of temp. So the baby's cold. And the grunting, I don't like the grunting. So that means the baby's really having some respiratory distress. So what are you going to do to help respiratory and thermoregulatory status? So people did a nice job with the thermoregulation, skin to skin, radiant warmer. And remember, when you put the baby under the radiant warmer, you're unwrapping them because you want as much surface area as possible under the radiant warmer. Put the hat on the baby. That's where they lose a lot of heat, is through their head. So make sure the hat is on. Skin to skin with a warm blanket is good. Making sure there's no drafts, make sure the baby, if they're not under the warmer or skin to skin, that they have clothes on and are swaddled. You can get warm blankets. But then what are we going to do about the grunting? So the grunting, what is the grunting telling us? So the grunting means that there's difficulty opening the alveoli and the baby's having to give pressure to keep the alveoli open to have that gas exchange take place. So what interventions are we going to perform? So we're going to assess, we're going to do a focused respiratory assessment. We're also going to do O2 sats. We're listening to the breath sounds, and then we can suction, right? We can use the bulb suction. If we need to, we can do a little bit deeper suction. We're going to kind of keep the baby upright a little bit for ease of breathing. O2 set, put them on continuous O2 set, notify the physician. Maybe the physician would want a chest x-ray potentially, things like that. And so different causes of the low temperature. You guys did a great job, probably from the hypoglycemia, but we don't really have a whole lot of information. So what information would we want? Has the baby been skin to skin under the radiant warmer? And then the cycle of low blood sugar, cold stress, and respiratory distress, right? Remember, keep them warm, pink, and sweet. So the more cold they get, the more energy they use. So the more glucose they use, and then the glucose gets used up, and then it becomes more difficult to breathe. And that can tip them into respiratory distress in a nutshell. So you're a great nurse, things helped, and everything are back in a stable range. So now James, we're on the next day, he's 25 hours old, and signs of jaundice begin to appear. And parents become more concerned when the phototherapy is initiated. So what factors may be contributing to the jaundice exhibited by James? So it's probably not pathological because it's happening after the first 24 hours. So it's probably physiological, maybe due to the vacuum assisted delivery, but it could also be, because we don't know, it could be the ABO incompatibility or an RH, and many of the other reasons that you all listed. But one of the key things would be the vacuum assisted delivery. We don't know how breastfeeding is going. Maybe there's some dehydration, things like that. Okay, and then nursing measures required. You guys did a nice job on this one as well in terms of the phototherapy being administered, making sure that the most surface area is under the lights, so or covering the genitals. Definitely eye protection is needed, and keeping the baby under the lights as much as possible. You can put warm blankets depending on the type of phototherapy that's being used, but the lights kind of keep them warm as well. You can also put the baby under the radiant warmer with the phototherapy. And so the type of phototherapy method, we talked about the Billy blanket being one because mom was breastfeeding, so that you would try and advocate for that. People had many different answers. I wasn't really looking for like the blue light or different types that way, although the answers that you provided were very good. It was more based on the breastfeeding and doing the Billy blanket. And so again, great interventions, the bilirubin level decreases to an acceptable level prior to discharge. So discharge teaching provided to hyperbilirubinemia. So great job. People talked about if the baby gets yellowish again, to call the doctor to have the bilirubin rechecked again. You want to keep the baby warm, make sure the baby's eating. You can also put the baby in sunlight because that kind of has its own phototherapy effect as well, and call the physician if there's any questions. So James' parents asked if James should receive the hepatitis B vaccine before going home. There were a couple students that I really liked their response, because you gave a response similar to actually having the conversation with the parents. And so the information was presented according to CDC guidelines and blah, blah, all the reasons why you want to do it. But they also included, I would give them the information, the website, the pamphlet, and I would tell them that it's their choice, that I'm providing the information, but it is their choice. And many of you went into the, at birth, 1 month, 6 months. So all that was good. But really it was that it's their choice is what we were looking for there. Breastfeeding, poor mom, she feels awkward and nervous, and she's probably feeling a little frustrated, many different feelings going on. And so how should you apply to the comments and help to enhance your breastfeeding skill and confidence? You guys gave great answers on that. What I especially liked was there was a couple students that sort of asked assessment questions. Can you tell me, how you're feeling? What's making you feel this way? Can you tell me, are you anxious? What's making you anxious? Or maybe some more informational questions. I thought those were really good. And then most everybody said we can get a lactation consult in. And many people pointed out that it's normal to feel this way, which was good, but you also don't want to minimize the anxiety. But we're here to support you, which most everybody said, which is great. And then, so the pediatrician is going to use a Plastibell to perform the circumcision. We also have to remember that the baby needs to have the vitamin K injection if there's going to be circumcision, because we don't want there to be a hemorrhage with the circumcision. And so you guys did a nice job of pre-procedure, making sure that there's a consent on the chart, explaining the procedure to the family, things to look at, things to look out for post-procedure. Many of you actually described the procedure, and then in terms of post-procedure education, you're watching for voiding and care of the circumcision. And so the Plastibell, my understanding was that we did not use Vaseline or petroleum jelly on the Plastibell because there's a plastic ring. But some of the literature that I found now says that yes, you do. So I'm not really sure. I know for other types of circumcisions, we use the petroleum jelly. You can put it on the head of the penis as well as inside the diaper where the penis would touch the diaper, and that way the penis or the ring don't stick to the diaper, which can be quite painful. And that they should watch for bleeding, and in terms of cleaning the area after urination or stool. Okay, discharge planning, critical assessment and care measures that they should learn. I loved it. Somebody learned CPR. I thought that was great. Yay. And so they need to understand about the feeding and keeping them warm and signs of respiratory distress, when to call the doctor, when the follow-up pediatrician visits are, any breastfeeding help or breastfeeding referrals, assess what their knowledge is as well. Make sure that they have a follow-up appointment with the pediatrician. And then what can they do to make sure their home is a safe place? And you guys did a great job in terms of, again, the back to sleep and the outlet covers. You don't need those yet, but, in ways to make the house safe, which I thought was great. Too many things to talk about that you could do. Everybody did a nice job with that. And so now we get to the car seat part. He asked whether it should face front or the back, and asked if you can place the baby in the car seat and help them put the baby in the car. What is your best response? So many people gave the information about forward rear facing when that happens, references on where to find that information, which was really good. What I was looking for is something to the effect of, we're not allowed, the policy, which many of you did, does not allow us to do that, and we would suggest, make sure you check with, the fire department, police department to do those checks. And hopefully they've done that, but we all know, we've heard stories that they pull the box out of the trunk and want help putting the baby in the car seat. And so, what are you supposed to do? It's that or not having the baby in a car seat. So sometimes that does happen. But those were the answers. What I was looking for with the case study, and it covered so much of what we talked about in terms of newborn adaptations. So I thought that was good. What was the other thing? Oh, I know what I wanted to show you for in Success. If you go to the modules for week 4, I added the schedule of quizzes and exams for second semester, so important dates. And so this will basically walk you through every week what the concept is and what quizzes that you have. And then in terms of, get through some ATI things in there. If there's no class, the skills, when the exam is, when your ATI things are due, clinical tools, your assignments for success class are there. There's another discussion coming up. So this will hopefully allow you to plan a little bit better, I guess, maybe in terms of workload for the weeks. And yeah, we don't have class that Thursday, so the ATI is in there. The newborn, that assignment's due, exam 2, and then the week after is the proctored, and then it's spring break, yay! And then we continue on. The skills dates may not be accurate because I know we have moved the newborn assessment, reconstitution, and postpartum assessment have moved up a week. And I believe we were going to move the IV out a week as well. That can be done in open lab when it starts back up this week on Thursday. And G's focus review. So basically week 13, you have the final, remember that's on a Friday. That would be, I'm thinking on campus probably, although we could do it proctorio, that's probably fine. And then basically done in week 14, the end of course reflection is due. So we're basically done with those. And then you have your community project. I haven't heard students talking about their community projects. I'm hoping that people are continuing to be out in the community and working with community partners to figure out what community events that you're wanting to prepare and implement in the fall or over the summer. You could do it potentially over the summer. And then your Pico paper and presentation, and the finals, and then pinning is on the 20th. I know they just had a meeting, so I know that that's moving forward, but I wanted to make sure that you saw that that had been, that's where that was added. And what else? I think, yep, so that's week 5. And then what we'll do next week after the exam, we'll have a Zoom to review the exam, to go over the exam. And then we'll just keep going along. So I think that is it. Let me look at pharm real quick. We don't have class. There's not assignment or quiz. So let's, because you have the exam on Monday, so no pharm quiz. There is quiz in 56, but that's going to help prepare you for the exam. Okay, so week 6, we're going to move into pain meds, which we've pretty much covered, and then pre and post-op meds, different anesthetics, different medications used pre-op, post-op, and most of them we've already covered. Things for nausea and vomiting, anxiolytics, things to help decrease anxiety prior to surgery. And what we'll do is, these are PowerPoints from Iggy's Med-Surg book, and so these will also be in week 7, will be what we'll go over in 56 as well. But there are some medications listed there. There's also some information on different kind of C-section closures, because you can use some anesthetics. It's called a Q pump that's sort of inserted in and that puts anesthetic where the incision is, and then left shift versus right shift in terms of infection. So there's some things there. And then you have the neurological system, and there is a case study. It's a shorter case study. Some students have done that already, and they're right on track for that. I also wanted to show you for week 6. I'm going to get I don't have the lesson yet. I will post that. That will be up by Sunday. But we talked about opioids last semester. We just reviewed benzos and barbiturates. You will learn about inhaled gases, ketamine, propofol, as well as neuromuscular blocking agents, and then lidocaine. Lidocaine is a local anesthetic. And we've already talked about antiemetics. We've covered anticholinergics, so that'll be review. If you don't remember, then go back to 49 in that pharm class, or look in your pharm book. And then various types of anesthesia. So local, topical, epidural, or regional, spinal, regional spinal block, depending on where it's more, a regional is more local. And then conscious sedation. You have your case study there that's due March 6th. And then you have the reading that's there for you to do. And again, review McQuistion because you've done those already. And then these are actually supplemental PowerPoints that I kind of put together from other sources that specifically really talked about the anesthetics. I feel in a better way than what McQuistion does. So you have those as well. And when I put the lesson together, I'll pinpoint specific things. And then these are what you need to know for the quiz that week. And so a lot of this is in the PowerPoints. And so the things that are sort of highlighted are probably what you're going to get questions on. For sure, you have to know malignant hyperthermia, spinal headaches when you have regional anesthetics. What's the interventions for that? Anti-nauseas. We'll talk about ketamine for conscious sedation. And then in terms of the paralytics, neuromuscular junction blockers, pancuronium is the exemplar. And so what are adverse effects? If you're given a medication that's a paralytic, what are you worried about? What is the main concept or the main area that you're worried about? Because things are going to be blocked. It's a paralytic. And why would we do that? Well, I can think of certain things like ECMO, extracorporeal membrane, when it's like a transfusion, like blood, it's kind of like dialysis, but it's like through the whole body. You're like doing a heart-lung bypass on the machine, and they have to be still because of the way that the lines are in. You don't want them moving. You don't want them fighting anything. Sometimes if they have to be intubated, you're going to use a paralytic. And if they need to be intubated and ventilated for a long time. But all this information will be in the lesson when I post that. But I just wanted to show you so you had it on tape for what is expected. And what else? And for 57, I will get those, the math questions out. And this week for 57, we're going to work on IV push calculations, and then we'll continue to do the skills testing. So when we did IV push last semester, it was in terms of saline flush. So it was kind of the psychomotor of it. And so now we're going to look at, okay, for example, I think some of you may have seen Toradol pushed in clinicals. And so you do a saline flush, you give the medication, you give a saline flush after. Well, you have to look up how quickly you can push the medication, because some medications you can push fairly quickly. Other medications are over 3 to 5 minutes. And so then you have to time that. And so we'll show you how to do that on Thursday. So I think that was everything that I had to share with you. So as usual, let me know, as usual, let me know, if you have any questions. I will see you Thursday in Skills Lab. And then in Success, I can stay late another hour to test anybody else. I got 3 people tested in that hour. So that was very productive. And we'll just keep moving along. So have a good night, and I will see you later this week.